Hello, Medicos. Good day to all of you. This is Dr. BK for you, and in today's class, I will be discussing about the remaining aspects of the pharynx. So, in the previous class, we have discussed about the extent, the overall relations of the pharynx, and followed by that, we have discussed in detail about the internal aspects, extent, and relations of the nasopharynx and the oropharynx, and we also discussed in detail about the palatine tonsil. Okay, now in this class mainly I will be discussing about the laryngopharynx and then the structure, muscles and vessels of the pharynx. Okay, so our learning objectives for today will be mainly on the extent, internal features and communications of the laryngopharynx. Followed by that, we will be discussing about the structure of the pharynx, that is the various layers of the wall of the pharynx, and more importantly the constrictor muscles and the longitudinal muscles. So their origin, insertion and their main action. Followed by that, I will be discussing about the blood supply, nerve supply and clinical aspects wherever applicable. So now first, coming to the laryngopharynx, it is situated behind the larynx, and that is why it is called as the laryngopharynx. So it extent can be from the upper border of the epiglottis, okay, to the pharyngoesophageal junction. So that is the extent from the upper border of the epiglottis to the pharyngoesophageal junction, and it communicates with the laryngeal cavity through the inlet. It communicates with the laryngeal cavity through the inlet only when the pharynx is at rest. That is when you are not swallowing any thing. Okay. If the food is passing through the laryngopharynx, then the inlet is closed and the communication is shut off. So it lies opposite the fourth, fifth and sixth cervical vertebra. So that will be the posterior relations, the vertebra with the intervertebral discs, and followed by that you will have the prevertebral muscles and the prevertebral fascia. Okay, then anteriorly, as I told you, there are the larynx, the opening inlet of the larynx and the posterior wall of the larynx. Above, it is continuous with the oropharynx. Okay, so above it is continuous with the oropharynx, and below it is actually continuous with the esophagus, but always kept closed by this upper esophageal sphincter or the cricopharyngeal sphincter. So the other relations, as I told you, above it is continuous with the oropharynx and below it is actually continuous with the esophagus, but that communication is actually kept closed by uh, the pharyngoesophageal junction, which is kept closed by the cricopharyngeal sphincter, or it is also called as the upper esophageal sphincter. So posterior relations I have already enumerated to you, that is the vertebra intervertebral disc followed by the prevertebral muscles. Okay, and then that muscles are again covered by a prevertebral layer of fascia. Between the posterior wall of the pharynx and the prevertebral fascia, there is a space which is called as the retropharyngeal space. Okay, now coming to the anterior relations, mainly it is related to the inlet of the larynx. So here you are able to see that is the inlet of the larynx. So the laryngopharynx starts from the upper border of the epiglottis. So the inlet is bounded by the epiglottis, by the arytenoid cartilages, and by this fold of mucous membrane, which is called as the aryepiglottic fold, and inside that the aryepiglotticus muscle is present. Now this inlet is closed when the food or the bolus passes through the laryngopharynx. Then below the inlet you are able to see this is the lamina of the cricoid cartilage. So that is the posterior surface of lamina of cricoid cartilage, and lying on top of it is the arytenoid cartilages. So everything is actually covered by the mucous membrane. Okay, so it is all lined by the mucous membrane. Okay, now the main feature you come across in the laryngopharynx. So what are the main features you come across? On the lateral wall, you see a deep depression or fossa-like structure that is called as the pyriform fossa. So a mucus-lined depression on either side of the inlet. Okay, now the bolus of the food, when you swallow, what happens is it passes on either side food channels, or of course it might also pass over the epiglottis. Okay, because the epiglottis is not going to fall back, the whole larynx is going to get elevated and it will get approximated so that the inlet is closed. So that we will discuss in the later part of this lecture. Now let us coming back to the pyriform fossa. So it is actually a deep fossa which is situated on the lateral wall of the laryngopharynx. Okay. Now what are the boundaries of this pyriform fossa or the pyriform recess? It is also called as. So laterally, it is actually formed by the lamina of the thyroid cartilage and the thyrohyoid membrane. Okay. Medially, you are able to see that is the aryepiglottic fold. That is the fold extending from the arytenoid cartilage to the epiglottis. This fold is actually called as the aryepiglottic fold. So laterally, the lamina of the thyroid and the thyrohyoid membrane. So they are all covered by anyway the mucous membrane. Now above, if you look, there is one more fold which is separating the pyriform recess. That is the lateral glossoepiglottic folds. Okay, and in the anterior part of the epiglottis, you will see one more fold, the median glossoepiglottic fold. So that part is actually the vallicular part. You can consider it as the vallicular part of the epiglottis or the vallicular part of the tongue. Okay, so the lateral glossoepiglottic fold separates this laryngopharynx from the vallicular part of the tongue. Okay, now what are the structures piercing this pyriform fossa? So it is mainly pierced by the internal laryngeal nerve. So the internal laryngeal nerve pierces the thyrohyoid membrane, then the mucous membrane, and then it is seen in the pyriform recess along with the superior laryngeal vessels. So they pierce the lateral wall and then they pierce the medial wall. Mainly they are entering into the cavity of the larynx to supply the mucous membrane of the cavity of the larynx. So on their way, actually they are passing through this pyriform fossa, which is a part of the laryngopharynx. So the lateral view or the external view, you are able to see that is your lamina of the thyroid cartilage, and this will be your hyoid membrane, and extending is the thyrohyoid membrane. Okay, between the hyoid bone and the thyroid cartilage. So that thyrohyoid membrane is actually pierced by the internal laryngeal nerve. Once it is pierced, now it is inside the pyriform recess, which we have seen. Okay, now this pyriform recess is one place commonly the foreign body. So if children anything they swallow, or adults most commonly when we eat fish, naturally the fish bones might get impacted there. So it is trapped in this fossa. So if we try any home remedies, naturally most of the cases what happens is it might enter into your esophagus, then there will not be any problem. Okay, so if at all, if it is getting trapped very much in that, then you have to go for the surgical removal. So while removing the fish bone, should be very careful not to damage this internal laryngeal nerve. Okay, so that should not be damaged, and care should be taken to preserve that node while removing any foreign body from the pyriform recess. So next, coming to the structure of the pharynx. So here you are able to see the wall of the pharynx. with so many layers. So mainly the wall of the pharynx from inside outwards is mainly formed by the mucus coat. Then deep to the mucus you have the submucosa. Then you have one more membrane or a fascia like structure lining it, that is called as the pharyngobasilar fascia. Then external to the pharyngobasilar fascia you see the muscular wall of the larynx. So it is mainly made up of outer circular and inner longitudinal muscles. They are something like your wall of the gut. With the in wall of the gut, the remaining part of your gut, it is inner circular and outer longitudinal. But here, what happens is the circular muscle is present external, and the inner part we have the longitudinal muscles. This is all for the functional purpose. Okay, then followed by that you have another fascia which is actually called as the areolar coat, because we cannot strictly call it as fascia because it is loosely attached to the external surface of the muscle of the pharynx, and not only that, it is also ill defined. Okay, that is actually called as the areolar coat, and it is referred by some authors as the buccopharyngeal fascia. So now we will try to actually briefly understand about these layers one by one. So first, coming to the areolar coat. So here you are able to see the pharynx wall. You are able to appreciate the pharynx wall, and that is your in front your thyroid cartilage, cricothyroid muscle, and all those things you are able to see. And that is on either side you are able to see the contents of the carotid sheath. Okay, this is your vertebra. So between the pharynx and the vertebra you are able to see the space. Externally the pharynx is covered by this fascia which is called as the buccopharyngeal fascia. Okay, so it extends over also to the, if you trace it above it from the pharynx, it also extends over to the buccinator muscle. But this fascia is ill defined, as I told you, and it is actually, some people consider it as the epimysium of the muscle itself, which is ill defined and loosely attached, and poorly defined, and its existence is challenged by some authors, because if at all there is a fascia external, then it won't allow the expansion of the pharyngeal wall. So when the bolus enters, what happens is it has to bulge and then it has to contract. Thereby, when it contracts, the lower part has to expand to receive the bolus of the food. So this will not be possible if there is a tough fascia. So if at all that fascia is not tough, you consider it as a loose fascia or ill-defined fascia, then it is not worth mentioning the existence of that fascia. So the existence of this buccopharyngeal facial layer is somewhat controversial. Then lateral or external to the buccopharyngeal fascia, you have a space which is the retropharyngeal space. So this space is lined anteriorly by this buccopharyngeal fascia and posteriorly by the prevertebral fascia. Okay, so that is about this areolar coat. Coming to the next layer is the submucous coat. Okay, so deep to the buccopharyngeal fascia, you have the mainly the muscular layer. So muscular layer we will see in detail. Deep to the muscular layer, what you have is the pharyngobasilar fascia and then the submucous coat. Okay, so it is present deep to the mucous membrane. So all these muscles, mucous membrane. So your lymphoid tissue also are seen in this mucous membrane deep to the mucosa. No? In the last class, what we have seen is the pharyngeal tubal tonsil, and then the nasopharyngeal tonsil. No? All this is present deep to the mucosa, and submucosa has its own blood vessels, nerves, branches. Okay, branches of these blood vessels and nerves. Now, this submucosa only is thickened above as the pharyngobasilar fascia. So which means don't actually assume this is present only above. No, since the muscular layer is absent, you are able to see the fascia very well here. Otherwise, it lines the internal aspect of your muscular layer of the pharynx, which is called as the pharyngobasilar fascia. So here the upper border of the muscle actually is deficient. No, there is a gap between the uppermost border of the muscle and the base of the skull, and that part is actually filled by this thickening of the pharyngobasilar fascia. So it fills the gap between your upper border of the muscle and the base of the skull. Okay. Next is the mucus coat. So internally it is lined by the mucous membrane, and the nasopharynx is actually lined by the ciliated pseudostratified it is actually pseudostratified ciliated columnar epithelium, which is the lining membrane of the nasal cavity. So your nasal pharynx, I told you, it actually behaves like your nasal cavity itself because it represents your upper respiratory tract, and mainly it consists of pseudo-stratified, no, because they are single layer but they appear as many layers because the nucleus are present at different levels. There's only a single layer but appearing as different with the cilia. Then the remaining part of your pharynx, that is your mucous membrane of your laryngopharynx and the oropharynx, is actually lined by the stratified squamous epithelium. So that is the typical stratified squamous epithelium with the low columnar to cuboidal cells, polyhedral cells, and the superficial cells are actually they are squamous in nature. This is the epithelium of wear and tear, and here it is stratified squamous, non-keratinized. Okay, they don't have a keratin layer. Okay, so apart from that, there is a transition zone, that is where the soft palate touches your wall of the pharynx during deglutition, no? That nasopharyngeal isthmus. That place a transition zone is there where the pseudostratified ciliated columnar epithelium transforms into the stratified squamous non-keratinized epithelium. Okay. So, with discussing about the buccopharyngeal or the areolar coat, then the mucous and submucous coat, we will pass on to the main muscular layer of the pharynx, which is present as outer circular and inner longitudinal muscles. This outer circular is present in the form of constrictors of pharynx. So why it is called as constrictors of pharynx? Because when the food enters, it constricts the pharynx. So naturally what happens? The food comes down. This part has to constrict. So that is how the food is propelled downwards into the esophagus. So they are called as the constrictors of pharynx. And they don't form a complete tubular structure like you see in the esophagus or down below in the stomach. Okay, they can be seen only in the posterior and lateral parts, and anteriorly, since the wall itself is deficient, it communicates with the nasal, oral, and inlet of the larynx. Okay, so only in the sides and behind you can see these constrictors, and see they are actually transversely oriented, so they are circular. Especially here you will be able to see in the junction between the pharynx and the esophagus. But in the esophagus you are able to see these muscle fibers are longitudinally oriented. So it is outer longitudinal from the esophagus, but here it is outer circular in case of the pharynx, which represents your the cranial part of your gastrointestinal tract. So we will actually now discuss about the superior, middle and inferior constrictors of the pharynx one by one. So they take origin from the bones, cartilages and ligaments from the sides, and they are inserted posteriorly into the posterior midline raphe or median raphe, you can call it as, extending from the base of the skull to the pharyngoesophageal junction. That is the posterior midline raphe. A raphe is nothing but the intersection of the muscle fibers. And see, the fibers, they sweep, okay, upwards, and they also fibers, middle fibers, they are actually transversely oriented. Lower fibers, they sweep downwards. So thereby it appears they are stacked one above the other. So the one overlapping the other. Now for example, the superior constrictor is lower part is overlapped by the upper part of the middle constrictors. Okay, then the lower part of the middle constrictors is overlapped by the upper part of the inferior constrictors. This is how they are present, like one stacked on the other, like your flower parts. You just put one flower part into the other. So that is how the superior, middle and the inferior constrictors are actually arranged. Okay, so now coming to the superior constrictor. So you're able to see a lateral view, and that is a posterior view, one half of the pharynx you are able to see here. The superior constrictors takes origin from the medial pterygoid plate. Okay, so this is the lateral pterygoid plate, and more medial to it you will see the medial pterygoid plate, and you have a process called as the pterygoid hamulus. Extending from the pterygoid hamulus is the pterygomandibular raphe. So from all these you can see the superior constrictor taking its origin. Okay, so that is the superior constrictor from the medial pterygoid plate, pterygoid hamulus, pterygomandibular raphe, and then also from the mylohyoid line of the mandible, which is present on the deep surface. Okay, mylohyoid line of the mandible. Okay, so from there it arises and it gets inserted into the posterior midline raphe. So the fibers pass or sweep backwards and then upwards, and posteriorly you can see it is getting attached to the pharyngeal tubercle. The tubercle you can appreciate in the basi-occiput bone on the base of the skull. Then the remaining middle fibers they sweep just transversely, and the lower fibers they pass deep to the middle constrictors, or the vice versa you can tell it is overlapped by the middle constrictors, the lower fibers of the superior constrictors. Okay, so that is about the superior constrictor muscle of the pharynx. Next, coming to the middle constrictor muscle of the pharynx, it arises mainly from the hyoid bone. Okay, so here this is the hyoid bone with the lesser horn and greater horn, and it also takes origin from this ligament, stylohyoid ligament, from the lower part of the stylohyoid ligament. So mainly from the hyoid bone, greater and lesser horn. So this muscle, if you remove the hyoglossus, then you can see deep to it, that is the middle constrictor muscle, greater and lesser horn of hyoid bone, and also from the lower part of the stylohyoid ligament. So again it inserts into the midline raphe. So we have seen the superior constrictors. This is the pterygomandibular raphe. From the pterygomandibular raphe, superior constrictor passes backwards. The buccinator, especially the middle fibers of the buccinator, arising from the raphe and passing forwards. So this is your middle constrictor of the pharynx, which is arising from the hyoid bone and lower part of stylohyoid ligament, inserting into the midline raphe. So here, so the upper fibers again they sweep upwards to get inserted, and the lower fibers are seen deep to the inferior constrictor. Actually, these lower fibers of the superior constrictor, the middle constrictor, and the inferior constrictors reach up to the level of the vocal cords of the larynx. Only the level, not to the larynx, up to the level where the vocal cords of the larynx are present. So to that extent they actually they pass, and that is they are reinforced, especially this posterior wall is actually reinforced by all the three sets of the subconstrictors of the pharynx. So upper fibers they overlap the lower part of the superior constrictor, and lower fibers are overlapped by the upper part of the inferior constrictors. Now, inferior constrictors, there is a slight difference in the structure. You can appreciate it as two parts. So, the upper part is actually called as the thyropharyngeus, and the lower part is actually called as the cricopharyngeus muscle. So, inferior constrictor has two parts. One is the thyropharyngeus, and other one is the cricopharyngeus. So let us discuss about the origin insertion of the thyropharyngeus first. So the thyropharyngeus arises from the oblique line of the thyroid cartilage. So this is one lamina of the thyroid cartilage. It mainly arises from the oblique line of the thyroid cartilage. Okay, and then also from the tendinous arch, you are able to see that extending between the thyroid and the cricoid cartilage. So this tendinous arch passes over the cricothyroid muscle. So that is your cricothyroid muscle, which is a muscle of the larynx. So from this the fibers they arise and they are inserted into the midline raphe. Okay, whereas the cricopharyngeus muscle arises mainly from the cricoid cartilage. Okay, from the anterior arch of the cricoid cartilage. And what happens to the fibers? They actually don't insert into the posterior midline raphe. Only the thyropharyngeus part it is inserted into the midline raphe, whereas the cricopharyngeus part they sweep backwards continuously and they are continuous with the fibers of the opposite side, and thereby they form a sphincter, that is the upper esophageal sphincter, and this part is always kept closed, whereas this part of the pharynx is open. They constrict or contract only when the bolus appears, but this is the reverse in case of the cricopharyngeus part. They are always kept closed. Only when the food enters below the thyropharyngeus, then actually it relaxes to actually allow the food to pass to the esophagus. So that is why it is more of sphincteric in action. Only when the bolus enters, the cricopharyngeus part relaxes. So that is about the thyropharyngeus and the cricopharyngeus muscle. Now, when this is about the constrictors, the superior, middle and the inferior constrictors, now let us discuss about the sinus of Morgagni. So as I told you, between the base of the skull and the upper border of the superior constrictor. The superior constrictor, only the posterior midline attaches to the raphe and to the pharyngeal tubercle. But here there is a space which is lined only by the pharyngobasilar fascia, and mainly it is pierced by the auditory tube, pierces and opens into the lateral wall of the nasopharynx. So one structure which is passing through the sinus of Morgagni is the auditory tube. Then you have some arteries and one more muscle, the levator palati muscle. So here you are able to see the levator palati muscle again coming through the sinus of Morgagni. Okay, so that is the levator palati muscle. This should be the upper border of your superior constrictor, and this white color is your pharyngobasilar fascia. It pierces the pharyngobasilar fascia, auditory tube, followed by that the levator palati muscle, which you are able to see here. Then you have a set of arteries, ascending palatine artery. So here you are able to see that is your pharynx. No? So from the upper border you can see these two. One is the ascending palatine branch of the facial artery, which is considered as ascending palatine artery, how it enters. Okay, that is should be your facial artery. And other one is the ascending pharyngeal artery, palatine branch of the ascending pharyngeal. So the ascending pharyngeal artery gives ascending pharyngeal artery gives palatine branch. So these two, along with the levator palati muscle and the auditory tube, pierce the sinus of Morgagni. So that is above the superior constrictor. So between the superior and the middle constrictor, mainly you come across the stylopharyngeus muscle along with the glossopharyngeal nerve. Stylopharyngeus muscle with the glossopharyngeal nerve. Okay, and then here you are able to see between the middle and the inferior. Between the middle and the inferior, you see mainly the internal laryngeal nerve. Okay, so mainly you see the internal laryngeal nerve and superior laryngeal artery. So the internal laryngeal nerve with the superior laryngeal artery, which is a branch of superior thyroid artery. Okay, so that is the superior thyroid artery, internal laryngeal nerve with the superior thyroid artery. Okay, so that should be an external laryngeal nerve that does not pass between, it is seen over the inferior constrictor. Gap between the superior, inferior and the middle constrictor is by the what you see here is the internal laryngeal nerve and the superior laryngeal artery. Then below the inferior constrictor, so that is your inferior constrictor and this is your esophagus. Below these two, especially in the tracheoesophageal groove, you see the recurrent laryngeal nerve. So you see the recurrent laryngeal nerve and with the inferior laryngeal artery, which will be given by the inferior thyroid artery. So inferior thyroid artery will give inferior laryngeal artery. So these two are the structures. Below the inferior constrictor, it is the recurrent laryngeal nerve and inferior laryngeal vessels. Above the superior constrictor, that is between the superior and base of skull, the sinus of Morgagni, the structures passing through it. Levator villi palatine, auditory tube, and ascending palatine branch of facial artery, and palatine branch of the ascending pharyngeal artery. Okay, between the middle and inferior, you have the internal laryngeal nerve and the superior laryngeal artery, and between the superior and the middle, you have the stylopharyngeus muscle with the glossopharyngeal nerve. Okay. Next, coming to the longitudinal muscle of the pharynx, it is present deep to the circular muscles, that is deep to the constrictors, and they don't form again a continuous coat, they are only discontinuous. Okay, they form a longitudinal, but they are not present all over the wall. They are concentrated as only three longitudinal bands. So they can be considered, these three muscles are your palatopharyngeus. Okay, so this is actually your palatoglossus, palatopharyngeus. You are able to see here. The other one will be the salpingopharyngeus. The other one joining between the superior and the middle, it pierces. That is your stylopharyngeus with the glossopharyngeal nerve. So that is the glossopharyngeal nerve with the stylopharyngeus muscle. So three muscles are the one. First I told you is the stylopharyngeus muscle, origin from the styloid process. Okay. The next is the palatopharyngeus, which arises from the soft palate, under surface of the soft palate at two fasciculae, anterior and posterior fasciculae, because the levator villi palatae is actually passing between the two fasciculae. So all those details of these palatopharyngeus, salpingopharyngeus, I have already discussed in the pharynx, the previous class, as well as the palate class. So kindly refer to the palate class for detailed description about the palatopharyngeus. Okay, so here you are able to see the stylopharyngeus muscle between the superior and middle constrictor. It is entering, and that is the fasciculae of the palatopharyngeus. Okay, but the levator villi palatae will be passing through that two fasciculae. Then from the lower part of the auditory tube, you have the salpingopharyngeus. Okay, so the salpingopharyngeus is also considered as the additional what do you call a additional part of the palatopharyngeus itself. But since it is arising from the auditory tube, we actually consider it as the salpingopharyngeus. So these three muscles, 1, 2, and 3, they all actually, what happens is they unite and they get inserted into the posterior border of the lamina of the thyroid cartilage. So here they are getting inserted into the posterior border of the lamina of the thyroid cartilage. These three longitudinal muscles, salpingo, palato, and then what you see here is the stylopharyngeus muscle. What is the action of these longitudinal muscles? So before looking into the action, they elevate the larynx. They elevate the larynx when the bolus of food is actually entering into the pharynx. So thereby the inlet is closed. So this is elevated or approximated towards the epiglottis, and the whole larynx as a whole is actually elevated upwards. Okay, so not only that, the palatopharyngeus also shortens the pharynx. Okay, so let us try to see that. So here you are able to see, yes. So did you see that the pharynx has gone above? This is a MRI video taken during deglutition. So bolus of food, when it is passes, kindly look what happens. The epiglottis does not fall back like a lid. It is actually fixed. The whole larynx is elevated and here the passavans ridge will be present. Palatopharyngeus will pull forward, and the nasopharyngeal isthmus will be closed by the tension of the soft palate. Elevation and tension of soft palate will approximate and close the nasopharyngeal isthmus. Same way, oropharyngeal isthmus also will be closed. So that we will discuss at the end while enumerating the steps of the deglutition. So now again, you watch once again carefully. When the bolus of food is passing, the larynx is elevated, which is mainly by the longitudinal muscle of the pharynx. So food is there. Yes, the larynx goes above. Okay. So longitudinal muscle, they elevate the larynx and shorten the pharynx during deglutition. Then additional action is constrictors, they propel the food downwards. So they constrict the pharynx, the food goes bolus downwards. This part is constricted and actually it is propelled downwards. So palatopharyngeus, as I told you, closes the nasopharyngeal isthmus by approximating the palatopharyngeal arch and bringing the passavans ridge, thereby closing the nasopharyngeal isthmus. The nasopharynx is shut off from the oropharynx, so that bolus does not enter into your nasal cavity. Okay. Now, with respect to the constrictors, you are able to see there is the inferior constrictor has got two parts, thyropharyngeus and cricopharyngeus. So thyropharyngeus, since it inserts into the posterior midline raphe, and it is also reinforced by, as I told you, the superior and middle, they pass deep up to the level of the vocal cords of the larynx. So the reinforced by the all three constrictors. But the cricopharyngeus, it's a circular and acts like a sphincter. These muscles, they don't go and reinforce. So between the junction between this crico and thyro, you have a weak area which is actually called as the Killian's dehiscence. Okay, so this area, the junction of the thyro and the cricopharyngeus, is actually called as the Killian's dehiscence. Okay, now coming to the nerve supply of the pharynx. So coming to the nerve supply of the pharynx, all the muscles of the pharynx, motor nerve supply through the pharyngeal plexus. So first I will enumerate the nerves, motor nerves. They are mainly supplied by the cranial part of accessory nerve. So the 11th cranial nerve, which comes out through the jugular foramen, 9, 10 and 11. So you are able to see 9 and 11 mainly comes out through the jugular foramen, the cranial part of accessory nerve. But these fibers will travel only with the vagus nerve. Only with the vagus nerve. Okay, the branches of these cranial part of accessory nerve, they travel with the pharyngeal branch of vagus, and they supply mainly the constrictors of the pharynx and your not the stylopharyngeus, palatopharyngeus, and your salpingopharyngeus. Okay, except the stylopharyngeus, which will be supplied by the glossopharyngeal nerve. So the glossopharyngeal nerve, along with this the stylopharyngeus muscle, will enter into the pass in the gap between the superior and the middle constrictors, the stylopharyngeus and the glossopharyngeal nerve. So stylopharyngeus is actually supplied by the glossopharyngeal nerve. In addition to this, the inferior constrictors, mainly it is supplied by the external laryngeal nerve, the thyropharyngeus part, and cricopharyngeus will be supplied by the recurrent laryngeal nerve. Okay, it's also believed that these fibers travel within these external and recurrent laryngeal, because they both are again branches of vagus. Through these branches, the cranial part of accessory nerve, they reach the thyro and cricopharyngeus part of the pharynx. So the sensory nerve supply to the pharynx, general sensations to the nasopharynx is by the pterygopalatine branches, and oropharynx is glossopharyngeal nerve, and the laryngopharynx is internal laryngeal nerve. Okay, so here you are able to see that oropharyngeal part by the glossopharyngeal nerve, which also is responsible for the taste sensations in this epiglottic area and area adjoining that, because posterior part of the tongue is supplied by the glossopharyngeal nerve. Naturally, it also supplies that epiglottic area taste sensations. and sensory is by the glossopharyngeal nerve to the oropharynx. Above part nasopharynx is mainly by the pterygopalatine branches. Okay, and secretomotor fibers, mucous glands of the pharynx is again by the greater palatine branches of pterygopalatine and pharyngeal branches. So please refer to the maxillary artery and nerve lecture. In that I would have discussed in detail about the pterygopalatine ganglion, its branches, its pathway, secretomotor fibers, pre-ganglionic, post-ganglionic fibers. Okay, so mucous glands of the pharynx is by the pterygopalatine ganglion branches, meaning the greater palatine and the pharyngeal branches. Okay. So here you see the pharyngeal plexus, which is actually situated on the posterior wall on the buccopharyngeal fascia on top of the middle constrictor muscle. Mostly it is seen on the middle constrictor muscle of the pharynx. So this plexus has got a motor component which is by the vagus nerve carrying the cranial part of accessory nerve. Then it has got a sensory component which is by the glossopharyngeal nerve. Glossopharyngeal nerve contributing to it. Then it has got a sympathetic component from the superior cervical ganglion, which is actually vasomotor in nature to the blood vessels. So that is the component of the pharyngeal plexus. So arterial supply of the pharynx is mainly by the ascending pharyngeal artery. So it is supplied by the ascending pharyngeal artery, which is a branch medial, only medial branch of the external carotid artery. Then other arteries supplying the pharynx are ascending palatine branch of facial, then dorsal lingual branch of the lingual artery, and greater palatine, pharyngeal and pterygoid branches of maxillary artery. Okay, so these are the blood vessels supplying the pharynx. Veins, pharyngeal plexus of veins, they drain into the internal jugular vein after joining with the pterygoid venous plexus. So lymphatics, mainly they are actually drained by the retropharyngeal lymph nodes. So lymphatics into the retropharyngeal lymph nodes. From there they go into the deep cervical nodes. Okay. So that is about the lymphatic drainage. So clinical aspects, I told you this is a weak area called as the Clehan's dehiscence. Now, in certain cases, what happens when there is a neuromuscular incoordination? Food through propulsion enters the thyropharyngeus part. Now, when the thyropharyngeus contracts, the cricopharyngeus, which is usually kept closed, has to relax and allow the food into the esophagus. So, if there is a neuromuscular incoordination, then both contracts, thyropharyngeus and cricopharyngeus contracts. So, naturally, the bolus has no entry, does not gain entry into the esophagus. Then it will project or protrude backside, which is the only weak area of the pharynx, the Killian's area. It forms a diverticulum, which is called as the Zenker's diverticulum. So this might also lead to difficulty in swallowing when this diverticulum is formed, dysphagia or difficulty in swallowing. Okay, so this is mainly because of the neuromuscular incoordination where the thyropharyngeus has to contract and cricopharyngeus has to relax on upon the entry of the bolus. But if this does not happen, then the bolus projects as a diverticulum through the weak area, that is the Killian's area, forming a diverticulum which is called as the Zenker's diverticulum. Okay, so next, finally, we will just have a very short account of the deglutition part. Okay, so the deglutition part is three phases, takes place in three phases or three stages. So the first phase is voluntary, or it is also called as the buccal phase. So food is placed in the dorsum of the tongue. Okay, so the longitudinal muscle accommodates the food so that the tongue is made concave, and it is opposed to the soft palate by the contraction of the mylohyoid muscle. Okay, so the floor of the mouth is raised by the mylohyoid muscle, so the tongue will touch the soft palate. So because of that, what happens is the food is actually pushed into the pharynx. Okay, The food is pushed into the pharynx through the oropharyngeal isthmus. Now, what happens is the second stage is involuntary, the closure of the oropharyngeal isthmus. So that has to be closed. Closure of the nasopharyngeal isthmus and also closure of the laryngeal inlet, because nasopharyngeal isthmus has closed, otherwise food should enter here. So it prevents regurgitation into it. Oropharyngeal isthmus, which is by the palatoglossal arch and the soft palate. Not only that, the styloglossus pulls the posterior part of the tongue upwards. So this is also closed. The food cannot enter back into the oral cavity. Only the food has to enter downwards. So when it is entering, it should not enter again anteriorly into the larynx. So the whole larynx is elevated, which we saw in that short video. So the whole larynx is elevated, closing the laryngeal inlet, which is by the longitudinal muscle of the pharynx. So that is the second stage. So when the inlet is closed, nasopharyngeal isthmus is closed, oropharyngeal isthmus is closed. So here you are able to see nasopharyngeal isthmus is closed. The larynx is also closed when it is passing through the oropharynx and then into the laryngopharynx. Okay, so then closer, as I told you, these isthmus and propulsion of food by constrictors takes place, and it reaches the thyropharynges and finally the cricopharynges. So the cricopharynges is to relax and release the food into the esophagus. Okay, then what happens is the third stage takes place where the food enters into the esophagus. So the total time taken by the food to pass from the pharynx is only just 1 second, and then it propels through the esophagus is only 3 seconds to reach the uh, gastroesophageal junction. Here there is only a physiological sphincter. There is no what do you call, yeah, the anatomical sphincter. We cannot demonstrate any structural sphincter there. So the last two stages, that is the second and third stage esophageal phase, is involuntary. So it takes place involuntary. So that is all about the pharynx, and thank you very much for your patient listening.